Hello, everyone. Welcome to our AWARE webinar today on perinatal mental health. My name is Dr. Susan Brannick. I'm a clinical psychologist and clinical director here at AWARE. So I'm just going to take a moment or two to allow people to join, and we'll get going shortly. Just as we have people kind of coming in, a few words on AWARE itself. So for those of you who are new to our webinar series, excuse me, these take place on the second Wednesday of every month, talking about a range of topics around mental health. AWARE also provides free support services and education programs for anyone affected by anxiety, depression, and bipolar disorder, including those supporting a loved one. So we have loads of information on depression, anxiety, bipolar, as well as other mental health conditions on our website, aware.ie. So do have a look at that for more information. Excuse me. In terms of our webinar today, so we really welcome any questions that you might have. So you can ask them throughout the webinar via the Q&A box. So we'll do our best maybe to get to as many questions as we can. Often we can't answer all of them, so apologies in advance if we don't get to your specific question. Do talk to your GP or mental health professional or health professional after the webinar if you are left with any questions. So without further ado now, I'm delighted to welcome the guest panel today. So Maria Kane, Dr. Orla Conlon, and Dr. Richard Duffy. So just a brief intro for each of you. So Maria Kane, well, you're very welcome, Maria. So Maria is a health and wellbeing coach and mom of two to under five. She's currently working in the biopharmaceutical industry as a site manager, and her passion is helping people to thrive in life by removing barriers, stopping them. So you're very welcome, Maria. Thanks for joining today.
Having me.
And then Dr. Richard Duffy, who is a consultant in perinatal psychiatry working in the Rotunda. So Richard holds a master's in epidemiology and a PhD in mental health law and human rights. Richard was recently a guest editor for a perinatal edition of the Irish Journal of Psychological Medicine. So you're very welcome as well there, Richard. Thanks for joining today. And last but not least, Dr. Orla Conlon is a consultant in obstetrics and gynecology. Orla is the medical director of Marble Arch Health and leads a multi-professional team specialising in women's health with clinics in Enniskillen and Galway. She's always had an interest in perinatal mental health and believes in recognising and managing depression during pregnancy as well as postnatally. So you're all very welcome. Welcome, Orla. Thanks for joining today.
Thank you.
Looking forward to the discussion today on perinatal mental health and maybe to kick off, I suppose, maybe starting with you, Richard, about kind of thinking about the kind of time frames that this involves. So when we say perinatal, when are we kind of talking about?
Yeah, okay, yeah, no, a really good starting question. From a service point of view, the perinatal mental health service we think about from booking through to 1 year, but unfortunately that's just what we're funded for. In reality, perinatal mental health often starts much earlier. We see a lot of people with mental health conditions that will fall into the perinatal category in the next 2 or 3 years, and sometimes they're put on medications without too much consideration of that, unfortunately. And so really it is, I suppose, anyone who, you know, of childbearing potential, all the way from any time they have contact with mental health services, from then when they get pregnant all the way through their pregnancy. And we see that rates of mental illness probably persist as elevated up to at least 2 years, if not beyond that. So we'd love from a service point of view to be talking about a much longer time frame. And we would hope to, as the UK has done, extend their service through to 2 years. I'd also love to be able to support GPs up before that booking visit. And so it's definitely an area that has a very wide time frame, and I think it's much better to have that inclusive wide time frame. But yeah.
Yeah, that makes a lot of sense, doesn't it? So it's not, I guess it's kind of based on the person's needs rather than kind of service kind of makeup in a sense. Yeah. And that can span a fairly long time. I wonder if we think then about kind of maybe the sort of the time before pregnancy or kind of the leading up to that. And maybe kind of continuing on in that theme, Richard, kind of what sort of mental health difficulties can kind of arise around that time?
Yeah, there's a huge amount of things. So lots of people have pre-existing mental health conditions, which obviously can be very challenging. Lots of people then as they're attempting to become pregnant, they sometimes make changes to medication, or life just becomes a lot more stressful. And so people often around that same time get married, buy houses, change jobs there, and that can really impact people's mental health. Other things that have huge impacts are IVF pregnancies, or as people are trying to conceive, sometimes people experience loss. For some people as well, they come to trying to have a pregnancy with pre-existing trauma, and that can be really challenging. And a lot of people, certainly 10-15% of people, would have like a primary tocophobia, so a fear of giving birth, and it's severe enough in quite a large cohort that it delays them having pregnancy. It often leads to people booking late, sometimes it leads to people considering terminations just because of that fear of giving birth. So there's lots of factors that are there even beforehand, even before somebody becomes pregnant.
And yeah, but that makes total sense, doesn't it? I guess you're kind of coming to this with all of your personality, your history, your life experiences. And I wonder, Orla, does that kind of tie into some of what you see as well?
Oh, definitely it does. And first of all, thanks for having me. I'm really pleased to be here, because it's such an important topic. And I think it really is looking at the holistic approach, to women's health, both physical and psychological, psychiatric. But yes, I suppose, as Richard said, anyone of reproductive age, from teenagers up to late 40s for women, obviously can still conceive, because so many pregnancies may be planned, but so many pregnancies are unplanned too. And it's really about recognizing pre-existing mental health conditions as well as pre-existing physical conditions. And, a lot of women, their mood changes a lot, in relation to hormonal change. And some women, can have severe PMS, some women can have severe PMDD, which we're only really starting to talk about now. So that's even before you embark on actually being pregnant. But so those women are more likely to suffer from perinatal depression. And I suppose we very much, in the past have thought about postnatal depression as being the important factor, but we do have to recognize that depression during pregnancy and any mental health disorder during pregnancy can, be very overwhelming. So in relation to patients, when they do get pregnant, as Richard said, there's so many issues. The fear of giving birth, and that can be because they have perhaps been sexually abused in the past, or have had a very traumatic, whether it's childhood sexual abuse or have had a traumatic sexual experience. And body dysmorphia and change in body image is also massive, because if you imagine even physically what happens during pregnancy, that the uterus is obviously growing, there's so much blood going to the uterus, your blood volume is drastically increased, and your organs are working overtime. So, it's overwhelming for anyone. So never mind someone who has significant mental health issues. And then, of course, the symptoms of early pregnancy, particularly like hyperemesis, which is morning sickness, and morning sickness can be not just in the morning, it can be, throughout the day. So, that in itself can bring massive challenges too. And of course, even that can bring challenges if you are on medication, for absorption of your medication, if you're throwing up all the time, which can be significant. Also, a lot of the even early pregnancy symptoms can also have a big factor on your sleep. And then, of course, if you do have an underlying mental health condition, sleep can be one of the first things that can change. So sleep disturbance, particularly in early pregnancy, can then have a massive impact on your ability to cope the next day. And then as well, there is that overwhelming fear of, as Richard said, if you've had a miscarriage, or, for some women, particularly, for example, if they've had a previous stillbirth, if they've had a loss, that, that makes the pregnancy even much more stressful. So, those things just even in general, can be overwhelming for most women. But if you have a history of a mental health issue as well, those are going to be much more, serious.
It makes a lot of sense, doesn't it? I guess then that word maybe that we're kind of coming back to is that holistic understanding of the person.
Yes.
Yeah, and kind of seeing them in the longer term view, and that's sort of I don't know, I don't know if we're getting better at kind of understanding people kind of on a more psychological and social level as well. And I don't know, Maria, maybe it'd be good to kind of bring in you here as well and think about your experiences in that respect.
Yeah, it's interesting to listen to hear from the kind of, I suppose, medical side that we're looking at doing more, but I guess it's always focused on kind of the funding and, you know, what Richard was saying about like from booking an appointment to like 1 year. But I suppose one of the big things I thought was it's quite isolating. Like even like, so I had mine during COVID, but even at that, it's just, I'd be somebody who'd go look for information like from proper books or research papers, but I guess there's so much false information out there as well. And you go to your booking appointments and you're sitting there for 3.5 hours, 4 hours, which if you're busy at work is either, depending on how stressed you are, really lovely to have peace and quiet or else stressful. But I suppose the one thing that I have learned from facilitating with Aware is the power of the peer support. And I think that the medical institute can only do so much. But if we put together the people who were going through the same stages and the same weeks, the same months together, they'd be able to support each other in a much more supportive way, because it's one thing sitting and talking with your medical person. And I think there's a lot of research out there about how much you take from a medical person as opposed to a peer person who looks like you, who's going through the same as you, which is why we need to be careful too. But if they were sitting for those 3.5 hours speaking with the same people every month for their booking and appointments and like really getting that engagement and chat, they'd be a lot less stressed and more calm, that they'd be able to kind of talk these through things and know that they had people on the same steps as them. And I think it's kind of that, it's not an empowerment thing, but getting back to, you know, listening to yourself as well, and not putting the pressure all on the medical team either, to have all the answers. Because I think you go to the medical team and you're waiting there for 3 hours and you have your list of 5 or 6 questions, and then you get in there and you get all flustered. Whereas really you just needed that kind of care and attention. I think really that's what you need, is that kind of reassurance, which is coming back to the holistic view of, you know, really being listened to. And I guess for me, the biggest part was we weren't set up to even know about this. You know, we're set up to go to school, go to uni, get the good job, get to all this. And at no stage were any of us being talked about our emotional health and like life stages about, you know, this is what's going to happen here. It's kind of like you get to each life stage and, oh my God, where did this come from? How did nobody told me about this. So I feel like with education, as we all know, knowledge is power, that if we kind of were able to educate people earlier on in stages, because it's kind of a taboo still sometimes, a lot of women's health issues. And you're always kind of, and I suppose with me, my first introduction to kind of Aware was on my first little fella. I didn't know how I knew I wasn't feeling right, but I couldn't have put a term on it. And when I had been to the meetings on postnatal depression, they were very severe outlooks they were giving. They weren't giving like, you know, just not being yourself. And so for me, it was very hard then to speak to people. So Aware's life skill online really helped me to kind of be that bridging point to kind of do something. But yeah, so it's interesting. It's very interesting.
Yeah, it is. And I guess, as you say, the importance of the kind of peer support and maybe the isolation. And I don't know, kind of for everyone, I suppose that idea that traditionally maybe it's kind of been postnatal depression is sort of understood quite well, but not, as we're saying, the whole kind of longer time period and maybe someone kind of coming into pregnancy with as you said, kind of maybe that fear of giving birth or kind of pre-existing difficulties. And it's an interesting point you had also raised there, Orla, about even kind of getting vomiting might affect kind of medication absorption. And I wonder kind of how do those conversations happen, or how does that work, I guess, in terms of managing that body and mind sort of interaction? I don't know, maybe for Richard and Orla. Yeah.
Well, first of all, I think Maria, you know, has a very good point. And even just, I suppose now with social media, I've started to do an Instagram series on women's health, and it is trying to reach out to people and educate them, you know, in their own environment, as opposed to having to be face to face, you know, doctor patient, because, you know, we do have to educate women. Well, I talk about women all the time because obviously women are the only patients that I see, but we have to also remember the men, because, you know, it can be extremely stressful for them watching their partner, you know, in going through this, and men feel so helpless because, you know, they can't really do anything. But I think the isolation, what Maria mentioned, is massive. And I think it's really important for women, from the likes of through Aware, to know that they're not on their own. And a lot of the things they're going through, you know, is normal to a large extent in relation to pregnancy. And like, no one wakes up and said, you know, today I'm ready to become a parent. Being a parent is the most scariest thing in the world. I mean, I go to work for an easy life, to be at home and being a parent. You know, you go to work so you can get your hot tea or coffee, or you can get meals at certain times. But, you know, being a parent is really scary, and being pregnant, particularly for the first time, is also very scary. And as Maria said, it is isolating. But one of the things that I picked on what she said too is, you know, women know their own body, and it's actually really hard to put it into words, but you know there's something not right. And that's when you need to be able to, you know, approach other people. And it has always been a taboo subject, but I think with the likes of Aware, you know, it's making it much more talked about and open. And when you just don't feel right, that's when you need to seek help. And there's so much, you know, like online, on the likes of this webinar and other webinars that you do, and all the information that you provide. It's to know that you're not alone. But I suppose COVID really, really changed that, and really changed it for women during pregnancy. And, you know, the isolation was massive. And also then in relation to even giving birth, your partners were only allowed in for a very short space of time. Postnatal period was extremely isolating, and like, your own mother wasn't even allowed to be in the house. And, you know, to think about a new parent as a woman, and like the impact of family and close friends, and even to further that, you know, the mental health of the baby and the development of the child because of the social isolation. So, you know, and also one of the big factors for COVID, one of the first services that went, which I was extremely frustrated and very angry about, was the postnatal service for women. And the other thing is, I suppose, too, you know, and again, it's that, you know, ability to provide a service, and there's health economics, and, you know, trying to, you know, provide service to the masses, but trying to make it individual. But, you know, one of the big things from the postnatal check, you know, once the baby comes out, most of the time, all the focus is on the baby, and it's baby, and mummy a lot of the time is forgotten about. So as a healthcare professional, we have to really, you know, again, take a step back and look at the whole picture. Look at mummy. Does she look exhausted? Yes, she will be. But even things like self-care, is she able to look, you know, has she brushed her teeth? Has she brushed her hair? Self-care, even those wee signs, you know, is she eating? You know, like, those wee signs are massive, you know, thinking, oh, hold on a minute here, there's, you know, this person needs help. But when COVID, you know, the postnatal check just went out the window, and this is both north and south of the border. And to me, you know, that really put isolated women who are already isolated in extremely, extremely vulnerable positions. And I think we still don't realize even the impact of COVID. And now those women are going back to have maybe their second or third baby, and there's so much trauma there. Never mind whether you have a serious mental health issue or not, because it was absolutely horrendous. But then, you know, what was the other? There wasn't necessarily a different way of doing it. But I think, you know, what Sarah said, the isolation is massive, and we really have to, you know, be focused on that too moving forward, because of the outcomes of COVID. And now these women are coming maybe for their second baby, you know, after giving birth through COVID.
The one thing I would say about COVID is I actually enjoyed that I didn't have to tell people to stay away.
Well, that's a good point.
It was lovely in the booking appointments that you didn't have, like, so it's always very busy, and there's always loads of husbands, and most of them aren't as chivalry as they were before. So you could be heavily pregnant and they'd still take a seat. So it was actually lovely to have that peace and quiet. And then when you had your baby in the hospital, your husband had to book in to come in for like a half an hour. It sounds very harsh, but it actually was lovely, because you didn't have the people next to you with loads of people in the room, and it was actually nice. And then when you got home, you didn't have to worry about unexpected people coming in. And I know that sounds terrible, but it actually got you time to kind of settle as a team. And, you know, I think that's kind of what you kind of, I think if we all led with like what I need and what my kid needs, that's what we need, you know? And you didn't have all those opinions of people, oh, you should be doing this or you're doing that. And I was very fortunate that the health nurse that's in my local area, she was lovely. Like, so I remember I eventually went to a check-in when things kind of started opening up, and people were like, oh, my kid, I weighed my ticket there, my baby was this weight, my baby was this weight. And I was like, oh my God, am I supposed to be weighing my baby? What? He's fine, he's happy. And so, like, I think if without putting the strain on the service providers and the hospitals, like those meetups, like even during COVID as an extreme, if you're able, like a lot of us started meeting in parks then when we could, and we had that distance, and that was enough. Just it's the routine and it's the small things. And I know I facilitate the aware meetings, and that's just a general mental health. And it's just getting people to know that some days it's just about getting through the day, and like the baby's okay, and you know, I've got out of bed for 5 minutes. You know, like it's setting that realistic expectation that's probably not seen at all in the world. That would really help. And it does really help when you remind people you don't need to, because when we're at work we're used to ticking off 10 things, 20 things off our list. When you're going through that, it's okay to stop, it's okay to slow down, and it's okay to have 2 goals for the week, and that's it. And it's that permission and kindness that we kind of need to bring back to ourselves, I think.
I think like just what you were saying about the isolation, to go back for a second, I think one of the other things that really fuels that is the fear of maybe reaching out for supports. In any kind of talk I do on perinatal mental health, I ask what percentage of my patients do you think get referred to TUSLA? And everybody always gives double figure as answers. And it's probably well less than 1%, you know, and of that often it's just for support. And so there's a real fear about reaching out sometimes for help, especially for maybe more marginalized or vulnerable communities. And then, as you were saying, Susan, that we've done better with the term postnatal depression, but I think we probably should be talking about perinatal depression, that in the antenatal period, people often get depressed and are like, what is this? I know there's a postnatal thing. They're terrified about this cliff they're going to tip off after they deliver, but actually you're as likely to be depressed in the 2nd and 3rd trimester as you are afterwards. And again, we've done the depression side of it, and sometimes people get anxiety, they get OCD, or they get panic attacks. They're like, oh, this is weird. You know, I was prepared for depression, but I wasn't prepared for anxiety, and suddenly that's isolating. So yeah, there's just so many reasons that it can be very isolating.
And I guess it sounds like people will have lots of different experiences in that too, as we're saying, but maybe there is something around the kind of traumatic experience around birth as well, which maybe isn't so much spoken about, whether that's kind of the COVID related or the birth itself, and kind of how that is for people. I wonder, does that come up a bit, or how possible it is to kind of have those conversations in different settings
around trauma, and yeah, it's a fascinating area. I think there's beginning to be some momentum around the hospitals in Ireland becoming more trauma informed. It's a massive area where there's needs for really, really huge development. And in the Rotunda, we set up the first psychological birth trauma clinic in the country, and we now offer EMDR, we offer trauma-focused CBT, we have psychologists for people who might have more complex trauma, but unfortunately we can only provide that for people who are in the Rotunda. Now I think Cork have set up a second one, and it's brilliant to see, but it's a massive need that's there. What we see as well is that about probably, there's a lot of different, it varies hugely. We've actually found the rates of PTSD is quite low, but we've a lot of people who don't have PTSD, but they do have trauma symptoms. They have trauma symptoms that are really impairing their day-to-day functioning. They're taking away their enjoyment of early motherhood, and it's hard to find people who have the skills to kind of address the needs that they have and have that familiarity with the field that they can provide help to them.
And what would you say, I guess if someone's listened to this and maybe some of that might resonate, how would you describe those trauma symptoms that might not kind of fully be post-traumatic stress disorder, but kind of along that continuum?
Yeah, I suppose you see people who've had, firstly, the trauma is subjective. So you will have people who have really horrendous deliveries or have horrendous past that they then go on to have a complicated delivery, and they don't have trauma symptoms. And then you have people who have a birth that may have run objectively or to a clinician quite smoothly, but something about it was quite upsetting or quite traumatizing for the person experiencing. So it's very much a subjective experience, and I think it's important for people to understand that. And then there is a natural course of trauma. So the vast majority of people who have a traumatic experience over the course of a few weeks, that settles. And so to have traumatic experiences and to give them some time to resolve is very fair. But I think when you're 6 weeks, when you're 2 months, 3 months down the road, and there's trauma symptoms that are still very intrusive, and that might be traumatic re-experiencing. So it might be nightmares, it might be flashbacks, it might be that sense of kind of autonomic arousal. So it's that sense of just being on edge. You're incredibly jumpy. You're constantly on the lookout for threats. And then for some people, there's that kind of impairment of sleep, kind of high degree of irritability, and there's also avoidance. The thought of going back to a hospital, the thought of reattending their obstetric appointment, or to see a doctor, or even to see a public health nurse might be really overwhelming for them. And what we're finding is that some people don't tick all those boxes, and to have PTSD now, they keep pushing the bar up, so you have to tick all those boxes. But there's lots of people that are ticking one or two of them really clearly in a way that's really impairing them, and things aren't settling. And I suppose a GP is sometimes a very good first port of call, but also often sometimes not always. And so it's about looking for maybe a psychotherapist or a psychologist who might be in a position to provide something, seeking counselling in primary care or other services like that can provide some supportive work around that.
Yeah. And I guess I just maybe bringing you in there, Orla, as well. I guess kind of teasing that out too, I suppose, in terms of kind of the physical aspects of pregnancy and post-birth, and kind of how someone might, maybe that's for us all to think about, how someone might be able to kind of tease that apart. I know, Richard, as you're saying, maybe there's a bit of a settling period, but I don't know, Orla, if you might add into that, because I guess it is a time of upheaval and change and not sleeping anyway. And
yeah, I mean, it is a really, really challenging time, even as Richard said, some people, we think maybe had a very traumatic delivery and they've coped okay, and other people, it's really challenging. But, even just things like healing of the perineum, if your perineum breaks down, it's extremely difficult to function and look after a baby. And, one of the other challenges is, of course, breastfeeding and overwhelming pressure, and it's amazing, it's brilliant if you can maintain breastfeeding, but for some women it's just either not going to happen to do with the babies, their suck or their palate, or the woman, their nipples or their milk production or whatever. But for some women then that can be really overwhelming, and they feel a sense of failure, or they're not a good mother, or they can't provide, and then they're not sleeping or whatever. Or then if they got an infection or hemorrhage afterwards, but the funny thing is, when Richard was saying there about the trauma, like I see it even in women coming in for procedures. Like last week on one of my theatre lists, I had one lady, and the thing about even other gynecological procedures, or going for your smear, or going for any sort of health check in relation to women's health, that brings it all back. And there was one lady who gave birth 40 years ago, and because she was coming in for just a minor gynae procedure, that all just came back. She was very emotional. She had a traumatic delivery, and it was 40 years ago. Or women that would have lost a baby 40 or 50 years ago, when they're coming for a gynae procedure, or they're coming for a hysterectomy or a vaginal repair. One lady yesterday at my clinic, for example, she's actually a nurse herself, and she's got a vaginal prolapse, and she said, it's really got in on her mentally, and she just feels so down because it has such an impact on her quality of life. And that she's had 5 children, and that was going back to her births and whatever. And even then, things like some women, if they have incontinence after they deliver, I mean, that is really, really challenging. It's really, really common, and again, it's like a taboo subject in the postnatal period. And then some women maybe have a 3rd degree tear, and they're leaking from their back passage, which is horrendous. So all of those physical symptoms can have a massive impact on psychological symptoms. And then there's an overwhelming fear of another pregnancy, but
Yeah.
but like women do carry it. It's not, they carry it for life, and coming back in for procedures, that brings it all back.
I guess that's the thing with trauma, isn't it? For many people, it doesn't really matter if it was a year ago or 50 years ago. For a post-traumatic stress response, it has the same sort of experience for a lot of people. It's interesting too, isn't it, that idea that so many areas in women's health are so taboo. Even some of the things that you're talking about there, Orla, aren't often kind of spoken about. And kind of that interaction with kind of mental health, that these are kind of very obvious things that are going to affect someone's well-being. And Maria, as you're kind of saying there, I think a little bit earlier as well, and maybe we've touched on the kind of the taboos around kind of women's health that are kind of speaking more generally, but also on the other end of that continuum, the kind of how might we call it, the kind of social pressures, or the curated Instagram, and the kind of the perfect mother ideas. And that all kind of plays a role as well, doesn't it? I don't know, Maria, if you wanted to come in there at all, or
I suppose the big thing I was thinking about is the going back to work part. So there doesn't seem to be a transit. I suppose I would have been, I was a production manager when I went out with my two smallies. And it would have been my baby before them. It would have been my all, because you work so hard to train and go up through your levels and get your qualifications and work really hard to get to your role. And then through my pregnancy, I was like getting physio twice a week and stuff to keep going, because mentally I loved my job, so I didn't want to give it up. So it's like pulling my leg to get to work, because that's what I needed at the time. And then when I remember, because I've always been in the kind of a male dominated industry as well, and people used to be saying, oh, those people in that department, sure, they'll be having another baby next week or next month, and that was that kind of talk the whole time. And I even see it recently again, like when someone's pregnant, and like, sure, they're paid the same as that person, but they're not contributing as much because they're pregnant or they're back from maternity leave. And there's still a serious a gap there in the workplace about how we handle it. I inevitably actually burnt out of work because I loved my job and I loved my kids, and I couldn't figure out how to do it all for everybody. And I certainly wasn't doing it for me at all. And that was really tough emotionally. That was really hard. And it was the first time I felt even isolated from my husband, because nobody else could make that call for me about what I was to do. And nobody could say, this will help or that will help, or, it was really tough. It was really tough. And being in the workplace with smallies as well, if you're anyway conscientious, like you can't be sick because you've this person sick and that person sick, and it's a serious day-to-day stress about managing your team and managing yourself and then managing your home life. And I feel especially in the workplace, it's like people take off one hat, so they get in the door, take off their like anything to do with human family life, and put on the hat of being at work, and then you go back home again. And yeah, it's like I'm trying to figure out how we could support it and sort it out better in the workplace, because it isn't an easy solution either. And I don't think it's a balance issue. It's just how do you adapt a role, or how do you say, if you're in this role, you might need to, like, I needed to step away and go into another type of role because I couldn't be there all the time like I wanted to be. And the pressure was never spoken about. I think it must be ingrained in us, that unless you're busy and flat out, you're not productive. So yeah, it's still a day-to-day thing, and I currently nearly have a 5-year-old and a 3-year-old. But yeah, it's I suppose Aware really helped me by I facilitate weekly now with the peer support groups in Cork, and I'm very bad for doing anything for myself, so that's why I did that. And I love it. It's still the best part of my week. Going in, it's the only space I've ever been in where people are truly authentic, and they just are so honest, and it's lovely to be in. And I try to bring that into my workplace, and try and coach my teams and be really, lead with kindness, and start with there. If anything goes wrong, I always try and get my team now to say, right, there's something wrong with the process, not the person, and figure that out.
That sounds like a helpful approach. Yeah. And I guess, as you say, it's sort of balancing the different roles, isn't it? It makes me think of what you were saying there earlier, excuse me, as well, Orla, that kind of being a parent is such a massive role change. It's so huge. And as you say, Maria, then there's also the kind of you that's going back to work. So all of these things are going to affect kind of mental health and well-being generally, as well as all the physical changes that have happened. And I just maybe kind of moving on a little bit, I guess just maybe to say something about kind of bipolar and pregnancy, because I think around the perinatal period, I guess that's kind of a relevant area for us too, and aware. I don't know, Richard, if you want to speak a little bit to that before we get to some questions.
Yeah, I think it's a really important area, because you see people who go into a pregnancy with a history of depression, and there's a real pressure on, do I stop medication? Do I maintain on medication? And there's a need to kind of weigh and balance the risks and the benefits of each. But when you come to bipolar affective disorder, I suppose the risks can be much more significant. When you have I suppose the risk is something like postpartum psychosis, and when you look at rates of admission for women after delivery is the most likely time in your life to have a psychiatric admission ever, and it's by quite a magnitude. And that's because of predominantly postpartum psychosis. It can be a severe depression as well, but you can get people who have bipolar type 1. So type 1 is where people would have maybe manic episodes. So that might be psychotic episodes with their mania, or psychotic episodes with their depression, or mania that requires hospitalization. But if they're not on medication going through a pregnancy, it's probably a 50-50 chance that they would develop a postpartum psychosis. And a postpartum psychosis can be incredibly severe. It's a real proper psychiatric emergency, often requiring admission. And unfortunately in Ireland, because there is no mother and baby unit, admission means separation from baby in the early phases of the postnatal period, which is really, really sad. So we're always very keen to proactively manage bipolar affective disorder, make sure that people are on the best treatment for that. One of the other complicating factors is that the treatment for bipolar affective disorders have some additional risks. And so you're looking at drugs like lithium that are a game changer for people. There are people who are better on lithium and just don't respond to other medications, but lithium comes with some increased risks. You have some people who are on sodium valproate, which comes with massively increased risks, and that increasingly is not being used because of that. But even drugs like lamotrigine, their effectiveness can be compromised by the folic acid, but they need to be on folic acid because lamotrigine inhibits how folic acid is used. And so there's just a lot of risks that can come up for people with bipolar affective disorder, which might make them reconsider their medication. But if we haven't got their medication right coming into the postnatal period, then they're at huge risk of developing a postpartum psychosis. And if that happens, we just want to make sure that people have all the information they need beforehand as to where to seek help, what to do, what are the medications that could be helpful in this circumstance, what are the practical day-to-day things that we can do to reduce stress, so that if that does start to emerge, that we're trying to get on top of it as soon as possible.
It's quite an important area, isn't it? And I guess it sort of goes back a bit to, as you're saying, that kind of perinatal period can be quite expansive. So it's even having conversations maybe around medication and how that might be long before, as you say, or even in the planning. And obviously people's pregnancies are different, aren't they? But even if, and I think that's tricky to do sometimes in mental health or physical health settings that say, well, maybe, we're planning on having kids in a year's time or something, but I'm not sure about it. Or so it's maybe starting the conversations early too.
The perinatal services do, I said from booking to 1 year postpartum, but we do preconception counselling, and preconception counselling for people probably with the much more severe end of mental illness. So maybe with bipolar affective disorder, where there is a little bit of complication in the medications that they're on, or for people with depression who are maybe on 2 or 3 medications, or have been through a few medications, maybe had a few episodes that required admission. They're people that would be very happy to try and do a preconception counselling appointment with, and the 6 main centres all, I think, are offering preconception counselling.
Okay, that's really good. Yeah, it's good to hear that they're kind of happening, those sort of conversations, isn't it? And I guess maybe it sort of leads into what we had kind of wondered about, and maybe there's a question here about kind of help seeking. So I suppose it's interesting to say there's no mother and baby unit. I find that incredible. Even now, not one bed in the hall. As you say, that's the time you're most likely to have an admission, and we still don't have one. Because it speaks to kind of where women's health maybe might sit. So it looks like you're going to say something there, Orla.
Yeah, I was just going to say, just in all my time working in maternity and the stress that puerperal psychosis is such a stressful event, and actually one of my family members also had it too. And I suppose from that perspective, it becomes very personal. It was my first cousin with her first baby, and she's, has had bipolar and manic disorder, ever since. But I mean, it's a very scary time, and a lot of the time it happens in the middle of the night, and the pressure under the staff, the midwives on the ward, and junior doctors, and the healthcare assistants. We have to remember too that that it puts a lot of pressure on resources, and it's so important that all members of the team are trained, to look out for the different changes. And thankfully, it's not very common, but when it does happen, it's really, really serious. And I also actually worked in psychiatry for 6 months. I can only say I've only got a 6-month psychiatry hat, but I saw as well, patients being admitted to intensive care in psychiatry, and it's so scary. And then, of course, that is the time that a mother could potentially harm her baby, or could potentially harm herself. And a lot of the, the self-harm and the suicide at that time is very violent, and, is much more aggressive than would be at any other time, as Richard says, in a woman's life. But, for the healthcare professionals, day and daily on the ward, they, as well as looking after all the physical needs of the mother and baby, they also have to look after the mental health needs, and to be able to actually identify risks, because for these things, it's like anything in maternity or obstetrics, we're trying to be one step ahead, but some, to see things before they actually happen, or try to anticipate it. But, sometimes, that's very, very difficult. And like staff, midwives are like amazing. They've so much professional training, as well as looking after mother and baby mentally and physically. So their role is massive in this. But I wanted just to go back to maybe one wee thing, just because we never mentioned it postnatally, because that's another issue for women. Well, even fear of having sex during pregnancy, but sexual health after pregnancy, because there is this sort of, as you say, the social media, the rose-tinted glasses of how celebrities look, in their Hello magazine post-birth, and that's not real, or whether things are airbrushed or whatever. But, there's so much pressure on women, because, they're thinking about, maintaining a sexual function or going back to having intercourse, and that can be massive, pressure. I don't mean that they're put under pressure, but as a woman, trying to get back into that sort of feeling of wanting to be intimate with their partner, which is such an important part of a relationship and such a special part of a relationship. But again, the changing body image, the weight gain, the stretch marks, they also difficult, perineum, the stitches in the vagina. Most women, like, your vagina is never the same again after you have a baby. So, there's all of that pressure, and for some people that is overwhelming, and some women really, don't see themselves as the same person physically, and that can have a massive impact on, their mental health as well, and anxiety. And then the other thing is too, you kind of pain with intercourse post-birth, and so there's so many variables in relation to how a woman sees herself, her own self-esteem, her own body image. And I think we just have to, as Sarah says, it's the peer. I just think what she's doing is just unreal, and it's that talking to, like, who talks about that even to their closest friends, so it's just like normalizing, and say we can talk about these things, and to know that other women maybe are going through the same thing and the same issues. I just think that's priceless.
It's really important, isn't it? Yeah. And thank you for raising that, because like I said, again, as you say, it's sort of normalizing and trying to have these more difficult conversations. And maybe the central piece in that there too is, I guess, is kind of where then you get help, and maybe Richard, you could give a bit of a steer on the kind of services that might be around for people.
Well, just on sexual health, we do an awful job in psychiatry, because SSRIs really cause sexual dysfunction. And psychiatrists don't talk about it. So we talk about it a lot in perinatal, and often we actually end up changing antidepressants because of the sexual dysfunction that's caused by SSRIs. It's always hard to evaluate because depression as well impacts libido. And when you look though at the services that are available from a kind of sexual health point of view, there are sexual health psychotherapists that are around Ireland, but it's very piecemeal. Publicly, there are, I think, only a handful. I know Hollis Street has one. Unfortunately, we don't have one in the Rotunda. But then there's a few kind of private practitioners, and it's really hard to access services that are specifically targeted at that, which doesn't help the stigma, unfortunately.
Yeah, I guess we're not very good at having these conversations in medical settings or in mental health settings. So it's kind of maybe acknowledging that, you know. And in terms of more general mental health services, Richard, in the perinatal period.
Yeah. Look, I think because there are specialist perinatal mental health services in the 6 hub sites, that is Cork, Limerick and Galway, and the 3 Dublin centres. But if you're delivering in any of the other 13 obstetric hospitals or hospitals that provide obstetric care in the country, there is a perinatal mental health midwife, and they do an excellent job, but they are one person. And so often all they are able to do is link somebody with some services that are there. That might be community mental health teams, it might be GPs. So I think for a lot of people, a GP is an excellent first port of call, and lots of GPs have excellent experience in this and are very good. But we also see that isn't always the case, and so we often see GPs who panic stop medications, GPs who are kind of dismissive of concerns that people might bring. This is really, thankfully, the minority, but it is definitely something that people encounter. And so then I suppose it is looking at, there will be a mental health professional in each of those centres, even if it is only that midwife, and that midwife might be able to direct someone towards, be that the community mental health team, or be that some other therapist that is working in the area. I know there is now a kind of cohort of psychotherapists with an interest in perinatal mental health that are beginning to kind of come together, and I think it would just be brilliant to see that there, because even in the specialist perinatal mental health service, while we have psychology, we don't have that kind of psychotherapy, that more kind of supportive piece. The HSE has done a good job on some of the information, and if you Google HSE perinatal mental health, there's a bunch of flyers that come up that are actually quite helpful. They're fairly informative. That's there, and then I think as well, GPs are very well placed to direct people, because often during the perinatal period, it isn't necessarily a perinatal issue that's come up. For a lot of people, it is issues with housing. Sadly, rates of domestic violence go up during pregnancy, and it may be issues with money. And so there's often other services that can be helpful that GPs will be very familiar with, that they can link people with, or to kind of seek out some of those voluntary services themselves. And Aware is very well placed to support people in accessing those services, but also will provide services itself.
Yeah, well, that's really helpful. Yeah, so I guess it's sort of maybe kind of do one question there about maybe if a new or expectant mum and their partner, kind of where they might reach out to if they're kind of maybe having mental health difficulties, and maybe kind of, as you said, and probably the GP is maybe one of those services, the midwife speaking to them. The
GP,
or one thing as well,
sorry.
there, Richard, just about at a local level, the one big difference that I've noticed, because I lived in Scotland for 8 or 9 years, and it's the GP practice, like you said, they're our first port of call, and there's no information in them. Absolutely, because they're all private practices, there's no information. You can't, like, if you could walk into the GP practice and while you were waiting to see your doctor about something else, you could pick up a leaflet, or you could go on through the system and find out information. That would help, like leaps and bounds, having that port of call, like, or even having a nurse practitioner like they had in the UK, where you'd have that bit more time with them, as like, you don't always need I know you're talking about much severer cases, but the majority, we don't need that expert. We just need that time where someone's listening to us and cares about us in general. It doesn't need to be specific in a lot of the cases. But sorry, that's just me.
No, absolutely.
Yeah.
Yeah, no, I think that's really important. As you say, there's something about the kind of authentic connections, isn't there? So the maybe some of the, I know we've kind of maybe talking about the more severe end, or the more kind of more difficulties that can emerge in this period. But I suppose it's also important to say that there are kind of avenues for help and support, aren't they? That we are kind of moving the conversation along, and kind of there are kind of more services sort of springing up. And Maria, as you said, that authentic connection, maybe in the peer support is really key. It's really important. And maybe as everyone has sort of said, that kind of knowing your own body too, and knowing when something's not right. And then people are kind of good at doing that, and kind of having those, maybe kind of reaching out for help in that respect as well can be quite helpful. Because I guess it can be a difficult time, can't it? In terms of anxiety and low mood and on all the things that can happen, as well as all the positive parts as well, you know. So I guess it's important to say that there is kind of support available, isn't there? And that is around. Just thinking about, just kind of going through the questions there.
Is it worth saying a bit more about trauma, because that comes up in a lot of the questions, I think. And I suppose just to address one of the questions, when the question talks about us having a trauma-informed teams, and I suppose we've done a psychological birth trauma clinic, but actually I think Aidan is dead right. What is needed is that trauma-informed care permeates every part of a hospital, and it is in the design of a hospital's architecture. It is the training of admin and security staff. It is every part of a hospital that kind of really needs to have that trauma-informed care. And someone describes, you know, an awful but an all too common story of having a stillbirth and then being put on a ward with other women with their babies, and then having to kind of listen to other women and babies crying. And it's a really upsetting story, but unfortunately it is one that does happen, and that's the kind of thing that trauma-informed care wants to address. And so the running a psychological birth trauma clinic and trauma-informed care are two quite separate things, but there is overlap, and just for trauma-informed mindset to just permeate every part of healthcare is what's really needed, and there is a bit of a push coming for that.
I think it's growing, isn't it? And it's certainly, there's more of an awareness that's really relevant in across those kind of medical settings, isn't it? So it's certainly developing. There's a question here about whether there's a link between depression and anxiety during the pregnancy, and postnatal depression once the baby is born.
Yes. So I think there's definitely a link between depression, anxiety, and pregnancy. Even to separate depression and anxiety is probably a little bit artificial, and they're often very much two sides of the one coin, and they can and they don't have to just be caused by the pregnancy. They all sorts of other issues, as the writer of the question points out, can relate into it. It's not just the pregnancy, but pregnancy brings up, it's just a time of life where lots of things change, and change in life, positive or negative, is a risk factor for anxiety or depression to flare. And into that as well, you have all the hormonal changes that can be a major factor. So yes, absolutely, there's a link.
Yeah. And I guess then there's maybe something about having, as kind of we've been talking a lot about, kind of having those conversations with health professionals. And I don't know, Orla, if you wanted to come in on that, kind of what might kind of empower people listening here. And obviously it's not a one-person job, you know, it's kind of the health professionals have a responsibility too, but what kind of things might be helpful to think about raising some of these, or how to go about that, and maybe to you after as well, Richard.
Yes, well, I see one of those comments, and I can completely understand that, you know, they've commented that it's a discussion between health professionals here, and we are talking about, you know, we're trying to really explain, you know, what are the worst things that can possibly happen, and the reason that we're doing that is to try to help people understand that, you know, if you have any sort of feelings that you don't feel right, that, you know, to get help before it becomes catastrophic, because for some women and couples, you know, families, it can be catastrophic. But and it's in no way minimizing the anxiety that women are going through, and women that are listening to this, I'm just so sorry that you're under so much stress and anxiety levels, particularly, you know, around the time of giving birth. And, you know, all I can say is, you know, just to hang in there. And it's as Richard said, the GP is definitely the first point of call, and some people have the same GP for years, and some now there's much more difficulties within the GP services and, you know, coverage of GP practices. So you may be meeting someone for the first time, but I think, you know, it's really important to get the message across, particularly in relation to your symptoms, that you just don't feel right. You know, there's something not right. And I also think, you know, you have to sometimes be brave to maybe say that a couple of times to reinforce it. And as well as that, to think about, you know, whether this is keeping you up at night, whether it has affected your sleep, whether you wake very early in the morning and you can't get back to sleep, whether, as Richard says, you're having nightmares or flashbacks to a previous bad experience, or whether you have an overwhelming fear. And also then things like, you know, whether it has affected your appetite, or, you know, have you lost weight? If you are pregnant, you know, has the baby put on weight as much as what you'd expect? And, you know, so many women, although Sarah was saying that, you know, the COVID was a positive for her, but so many women, you know, they are very isolated. And as Richard said, they may be a victim of domestic violence. So, you know, even the likes of Women's Aid can be very supportive too. That, like Aware and there's a Birth Trauma Ireland organisation as well. So it's to reach out to people, as well as, you know, trying to discuss it with your GP. And you know, it isn't, as Richard said, just the, you know, the physical or mental or psychological symptoms. It's also the other things. And sometimes if you have an overwhelming fear of housing, or an overwhelming fear of paying the bills, if you did get some help with that, it might help anxiety. But there's lots of other, you know, different apps and CBT and different things that you can do in relation to psychological therapies that don't actually involve medication.
Yeah.
But one of the other questions too was about medication. And yes, of course, there's the risk of pregnancy and the fear of whether there's going to have any underlying risks to the baby. But I think in the very severe cases, it's really important to be on the medication to try to reduce the risk of a major trauma after giving birth. I don't know if that was very helpful, but it's really trying to get the message across. You know, to identify your symptoms so that you can actually explain it. But sometimes it's still okay just to say, look, I just don't feel right. I know there's something wrong. I just don't feel myself, and I really need help, because I can't live like, you know, I can't cope like this, and I need something to help or to speak to someone, you know.
Yeah, that's really important. Richard, do you want to come in there?
Yeah, just on two things on both ends. On the, I suppose, the milder end, I think you know, Maria, you pointed out that people were talking about this is how serious it can get, and I think in the comment section we're also, maybe myself and Orla, like, this is how serious it can get. But there's a lot of people who are having, you know, they're struggling a bit, and they want to know what's the first port of call. And actually, what I'll often say to people is, you're the expert in your own mental health, and talk to the family, have a look at things that have helped you in the past. If that's exercise, it might be looking at a different way that you can exercise. If it's mindfulness, that could be helpful. Again, to a lot of people, what I say is mindfulness is just so hard when you have a tiny baby. And so to maybe park the body scan, or park the other types of the 45-minute meditation you would have done, and spend 2 minutes with your baby, where you park the to-do list of, right, when I have to finish this, then I have to wash their clothes, and they've grown out of their clothes, and I have to buy more clothes, and just this eternal list of all the jobs you have to do. And it's to park that for 2 minutes and be really present with your baby, to notice what they feel like, what they smell like, the noises they're making, and to just be really kind of in that moment. And if mindfulness was helpful for you, that might be helpful for you. So to find the things that have helped you with mental health struggles in the past, and see if there's a way to kind of get a little bit of them into that kind of perinatal period. I think that's a really important thing. And also to say, people with perinatal mental health problems do really well. It's a reason why it's lovely to work in this area. People make really good recoveries, or function full entire recoveries, and function really well and make quick recoveries. So it is nice.
Yeah, thanks, Richard. That's a nice note to kind of end it on, in terms of the kind of the takeaway points. And then I guess, Orla, sorry, just before I say that, apologies if we didn't get to the question that you had. Do speak to your health professional if you're left with anything. But maybe kind of, Orla, coming to you for one or two last words, the most important thing maybe you'd want someone to take away with them from our webinar today.
Well, I think really, you know, a lot of these symptoms are very common, and I think, you know, a lot of women put themselves under so much pressure that, you know, as Richard said, you know, do just take time to yourself, and, you know, don't beat yourself up. That all of these things are very common, and that there are a lot of women, you know, struggling in the same way, but it is so important to ask for help, you know, before it gets to a bad stage.
Great, thank you, Orla. And Maria, last words from you about what you would kind of maybe want someone to take away with them from our discussion today?
Yeah, I suppose just be kind to yourself is the biggest thing, and just talk with people. And I think sometimes it's easier to talk with people who you don't know sometimes. Even like people randomly at a coffee, like the could you do meetup family groups all over Ireland, or journaling. And because I know I tried starting my meditation after Lucy and it was tough, so I actually did Tai Chi, which was movement meditation, which kind of got me used to the screaming in the background and the moving as well. So, but just try something small, and I think having something a bit of fun every day, like even 5 minutes or 2 minutes, just doing something fun just to break it up, can make a difference as well.
Great, thank you all very much. Thanks, Maria. Thank you, Richard. Thanks, Orla, for the discussion today, and thanks everyone for tuning in and listening. Hopefully it'll be of use to you. And then moving on to the webinar for next month. So we're going to be talking about our LGBTQ plus people at greater risk of mental health difficulties. So do join us then on the 12th of June for the discussion next time. Thank you all again, and see you soon.
Thank you. Bye.
Thanks. Bye.
Thank you.